I welcome you all. Very good evening. I welcome you all on behalf of the Sri Lanka College of Internal Medicine and its council, and to the fifth lecture of our therapeutic forum, which was introduced to enhance the clinical therapeutics among the members and the audience. Today, we will have an eminent speaker with us to update you on postmenopausal osteoporosis management. First of all, I would like to invite Dr. Kumuduni Jayasinghe, President, Sri Lanka College of Internal Medicine, to address you all. Over to you, madam.
Thank you, Dr. Anga. Good evening, everyone. I warmly welcome all of you to another engaging session on therapeutic forum organized by our college, the Sri Lanka College of Internal Medicine. I extend a heartfelt welcome and a sincere appreciation to today's speaker, Sarath Lekamwasam, a very valued member of the college and who always helps the college for kindly accepting our invitation. I think the discussion on this very important topic, postmenopausal osteoporosis, is of significant importance, and I'm certain this will address many of the uncertainties that we have regarding this condition. A special thank you goes to Dr. Ranga Gunasekara, one of our very active council members, for organizing this therapeutic forum and also taking part of the role as the moderator also. I invite all my colleagues, postgraduate trainees and fellow doctors to be a part of this enlightening lecture and engage in the subsequent discussion. Thank you very much.
Thank you very much, madam. It's my honor and privilege to introduce one of our beloved teacher, Professor Sarath Lekamwasam, to deliver the lecture on postmenopausal osteoporosis. When I asked for sir to deliver this lecture, without any hesitation, he agreed to deliver the lecture. And thank you, sir, for doing that. And plus, when I asked for a short CV to use as an introduction, he said, I don't need any introduction. Yes, sir, you don't need any introduction. You're the chair professor of University of Ruhuna, Faculty of Medicine, Galle. And you have done and engaged in extensive research on osteoporosis and its relevance to the medical field. And thank you very much for accepting our invitation, sir. Over to you, sir.
Ranga, can you see the screen that I'm sharing?
Yes, sir. We can see it.
Okay, right. Okay. First of all, thanks very much, Ranga, for the invitation, and also Kumudini, and to deliver a talk on this postmenopausal osteoporosis. I'm really impressed that, 790 odd people have joined, and I really thought that I'll be speaking to about 10-15 people, and I'm really impressed with the support that the network of the Sri Lankan College of Internal Medicine, and then 90 odd people, joining at this hour, and really impressive. My talk today, I'm going to touch certain areas, as Kumudini said, that there are certain uncertainties that you have to live with when you are dealing with postmenopausal osteoporosis. So I'm going to touch on osteoporosis, the introduction to osteoporosis, and also when to treat, how to treat, and also when to stop treatment. Now, these are the areas, actually, the last three are the ones which are really relevant and directly relevant to the clinicians who are looking after patients. And I will not probably mention too much about what's called epidemiology, and people can read about them. And it's a huge problem in the epidemiological sense, the pathogenesis and also causes. I'm not going to really dwell on those areas. It's very difficult to talk about osteoporosis without talking about bone mineral density. I'm not trying to underestimate your knowledge on bone mineral density, but just to introduce the concepts of bone mineral density, it is a density of the bone material in the selected skeletal sites. Now, the selected skeletal sites can vary, which some of are clinical relevant, some of them are relevant for the research. So whatever the site you select, what's called region of interest, and then it's a density of the bone material in that. So if you simplify that into, say, let's say bone mineral density equal to bone mineral content, that's amount of bone divided by the area, which comes in, let's say, square centimeters, and the bone mineral density will be expressed in terms of what's called gram per square centimeter. This is what's called actually aerial bone mineral density, which is used in clinical applications. But there's something called volumetric bone mineral density, which is used very much in the research. So I'm not going to touch on that. Now, this is what's called the dynamics of the bone mineral density during the lifetime. You can see there's an exponential rise of bone mineral density during, let's say, adolescence and the pre-adolescence during the growth years. And it comes to what's called the peak, and then what's called known as a peak bone mass. Since people achieve the peak bone mass, and there's a very little change in the bone mineral density since then, and you can see that with the onset of menopause, and then there's a sharp decline of bone mineral density, particularly seen in women, and then a curve of men is always stay above that of women, and then about 10 to 15% higher than women at a given time, and then that the rapid decline that you see at the after the age of 50 or 60 is not seen very much in men. So men, they lose bone mineral density at a slower pace when compared with the women. Women with the menopause or the onset of menopause, and with the hypogonadism that comes in, and then there has a rapid reduction of bone mineral density, mainly because of the loss of trabecular bone. So women enter into what is called fracture zone. The red area is called fracture zone. You can see that women enter into the fracture zone much earlier than men, and the men enter at a quite later stage of their life. Now, there is a structure of the normal bone. You can see how strong the structure. There are what are called the vertical trabeculae, and also there's horizontal, what are called horizontal crosslinks, and which are connecting vertical trabeculae. And one has to be very proud of having that kind of bone in your skeleton. This is what's called osteoporotic bone, and what's called micro CT film. And you can see what's called trabecular thinning, the thinning of the vertical trabeculae, and also particular loss of what's called connectivity. So the vertical connections are lost and they are breaking down. So what's called loss of connectivity and the thinning of the trabeculae. So whole structure seems to be quite unstable. It's a structurally unstable bone. Just a few words about these two types of cells, because they will become handy when you come to the discussion on the treatment. Bone is a dynamic tissue, and it is not the same bone mineral density that we are born with, that we carry throughout the life. It's a constantly undergo changes. And what happens is actually the osteoclast move into area, and which need to be relayed. And these are the areas which are called what are called microfractures. And usually our day-to-day activities, we do certain work, and when we run and when we do some let's say jumping and things like that, there are microfractures in the trabeculae. And what osteoclast, the big chap here, the osteoclast here, they move into the area where there's a break, and then they eat up the bone in that area and create what is called lacunae. It's create a lacunae, a small pit in that. And then subsequently osteoblasts move into the area and lay down the new bone. So two types of cells which are having opposite actions are the osteoclasts, which are what's called resorptive. They resolve the bone. And then what are called the bone forming cells, what are called osteoblast. Okay, so there are two different kinds of cells which are important in the understanding the drugs that we use in osteoporosis. This osteoclast has done its job, and then it's a multinuclear osteoclast that dug a pit, and then that is what you see in the this one electron microscope. Also, you need to know about what is called T-score, and the T-score actually the deviation of the patient bone mineral density from the mean value of the reference population is expressed as number of standard deviation. I'll go through again slowly. That is, let's say, if you take a patient bone mineral density and you see how much it has deviated from the mean value of the reference population. Now, the reference population that we take is what's called the age of 20 to 30 years. So it's a men or women, age 20 to 30 years is taken as what's called reference population. You take the mean value, you take the standard deviation, and then see how far it's the patient's value, and then express as the number of standard deviations. Now, for example, let's say if the patient's bone mineral density is here, right? And then this sample of this example in women, and then you can see this is a peak bone mass. So this is the mean value of the young reference population. So this line here, blue line, represent what is called the mean value of the young reference population. You can see how far it is deviated from here, and then you measure in the units of standard deviation. It comes to, let's say, -4 because it's below this -4 here. So that's what's called T-score. If you do a calculation again, let's say patient's bone mineral density is 0.600, and the mean and the standard deviation of the reference population 0.900 and 0.100. I got these numbers, wrong, all rounded off because is calculation. You can see that the patient bone mineral density is less than mean of the reference population. So the difference is about -0.300. When is it divided by the standard deviation, you get a -3.0, which is a T-score. So T-score is the measurement that we use when you're particularly talking about the postmenopausal osteoporosis. In 1994, for the first time, the WHO gave what is called diagnostic thresholds in postmenopausal osteoporosis. But remember, this is only valid for what's called postmenopausal osteoporosis, not for the premenopausal osteoporosis, not also for the, let's say, drug-induced osteoporosis. It's only valid for the postmenopausal osteoporosis. Because they use a large body of epidemiological data, particularly from North America and the European region, in order to find out the cutoff values, different cutoff values, what's called thresholds, in order to define osteoporosis. So osteoporosis is defined when the T-score is less than -2.5 or less, and then you consider that patient has osteoporosis. But if the patient has less than -2.5 and has got a fracture, what's called prevalent fracture, it's already got a fracture, and then you call that patient to have what's called severe osteoporosis. So severe osteoporosis is defined as somebody who has got a low bone mineral density and in addition has got a fracture, already got a fracture. This is a kind of DEXA report that one might see. You can scan what's called lumbar spine 1 to 4, and that is the usual what's called total spine is lumbar 1 to 4, and you can see you get an area here, and you get a bone mineral content, and then you have a bone mineral density, all of these measures that you know of, and then bone mineral content divided by area, and you get bone mineral density. These are what's called individual vertebrae here, 1 to 4, and then all 4 together, it's called total spine. You can see the bone mineral density expressed as a gram per square centimeter. And you can see alongside what are called T-scores here, and the T-scores, there are minus values here in this particular situation. And these are the area, clinical area that we use, what's called proximal femur. In the proximal femur, there are 2 areas that we are interested in, what is called neck of the femur, that is box here, and then other one is what is called total hip. So there's a neck and the total hip, and again, you get an area, bone mineral content, and bone mineral density, and together it's what are called T-scores here. So you can see, looking at the T-scores, and you can decide whether the patient has got osteoporosis. Just a run through the definition of osteoporosis, because there's a little bit of uncertainty about on this regards. It's a systematic skeletal disease characterized by 3 things. One is what's called low bone mass, a microarchitectural deterioration of the bone tissue, and a subsequent increase in bone fragility. So 3 components that are included in the definition of osteoporosis include that low bone mineral density, together with the microarchitectural deterioration and the increased fracture risk. So the consideration that some people think that when there's somebody has got low bone mineral density that is equivalent to osteoporosis, that doesn't work. because low bone mineral density is not synonymous with osteoporosis because it needs to be accompanied with microarchitectural deterioration and increased risk of fracture. So if those three are not fulfilled, then you can't just say somebody has got osteoporosis. For example, if you get a 35-year-old woman who's completely asymptomatic, otherwise normal, somebody for some reason, some weird reason has done DEXA scan and found the bone mineral density to be less than minus, let's say 2.6 or something like that, and then you can't just say that patient has got osteoporosis because it's not allowed to do that. You must have seen along the Z score, sorry, along the T score, there's what's called a Z score. And then the Z score is another measure which is used in osteoporosis. It's a deviation of the patient BMD from the mean of the age and the gender specific normal data. Right? I'll just give a little diagrammatic thing. Let's say, for example, the previous bone mineral density here. Now, instead of comparing with the peak bone mass here, now we compare with what is called age and the sex, age and the sex match normal values here. And you can see again expressed as standard deviation. In this situation is minus, let's say 2.0. So Z score is very much a measure which goes along with the T score, and it is interpretation of that is that if it is greater than minus 2.0, or shall I say lower than minus 2.0, minus 2.53 or something like that, and that considered normal. It is not the same cutoff value you take 2.5, it's a 2 actually, you take 2, and if it is more than minus 2, then of course you say it's considered abnormal. If there are postmenopausal women who has got osteoporosis on T score and has got abnormal Z score together with that, then you say there's a possibility of underlying disease, maybe multiple myeloma, malignancy, renal disease, or something operating in that patient, and in addition to postmenopausal osteoporosis. That is not a 100% valid rule, but again, there's a little suspicion on that, the possibility of underlying cause. But in the premenopausal women and children, you don't take the T score. T score is invalid because the T score is not validated among these people. The only measure that indicates somebody has got abnormal bone mineral density is a Z score. So a Z score in premenopausal women and children, if it is lower than minus 2.0, you say this person has got an abnormal bone mineral density, and the clinical relevance of that need to be decided depending on the patient's clinical picture. If there is a patient with thalassemia, the patient on steroid, then of course it becomes relevant. So Z score and the T scores are interpreted in a different manner. This is a C score. See the common site of fracture that all of you know, hip fracture, the most sinister complication of osteoporosis, and then comes the vertebral fracture, not as bad as the hip fracture in terms of impaired quality of life, and then comes what's called wrist fracture, and there's other fractures, what is called rib fractures, as well as the head of the humerus and neck of the humerus, and then neck of the humerus, and those are also considered to be what are called the osteoporosis related fractures. Indication for DEXA. Lots of people undergo DEXA for no good reason, really. But then in certain countries, it is very tightly controlled. For example, let's say USA. And the USA insurance companies, they know very well what are the indications for DEXA, and they would not reimburse. They would not reimburse for money for DEXA scan, spent on DEXA scan, unless the patient has got these valid reasons. But then it is not observed in Asian countries, particularly in Sri Lanka and all that, you know, somebody has got a, let's say, no good valid reason, people are sent for DEXA scan. Real indication, if it is a woman more than 65 years, regardless of the symptoms, that patient should have a DEXA scan. And if it is a postmenopausal woman who is younger than 65 years, mind you, it is a postmenopausal woman younger than 65, and that patient has a minimum of 1 clinical risk factor. So it's easy, a woman more than 65 years, regardless of the clinical picture, and a postmenopausal woman less than 65 years has to have minimum of 1 clinical risk factor to qualify for a DEXA scan. And when you come to men, you raise it to 70 and 70 or 75, and most of the guidelines say more than 75, but there are some guidelines say more than 70, and again, same thing. In addition, there are patients with the diseases which are associated with loss of bone mineral density, like inflammatory bowel disease, rheumatoid arthritis, inflammatory arthritis, and all that. And then there's indication for DEXA. And also patients who are on drugs which can cause bone loss, like, for example, heparin, and then, corticosteroids and all that, that may be indication for DEXA. And also others like, start on HRT, and then somebody might think of doing a DEXA scan. So there are other indications as well. The clinical risk factors that I said earlier, like, there has to be a minimum of one clinical risk factor. These are the clinical risk factors one would consider: a parental history of fragility fracture, a previous fracture, inflammatory arthritis, smoking alcohol, social habits such as smoking alcohol, taking glucocorticoids more than 5 milligrams of prednisolone for more than 3 months or more, and then other drugs, secondary causes of osteoporosis or fracture, and also there are other ones as well. Then recently included what are called falls, recurrent falls, also included in this under the risk factors. The second question comes, who should be treated like, that becomes a bigger question, like, deciding on the treatment is not such a tricky thing, but then deciding on who should be treated is the most tricky and the complex question that we have to face. The real world scenario, if you take, there's plenty of epidemiological data to say that there's under-treatment of those who with a high fracture risk. So despite the people are having high fracture risk, despite people are having fractures, and these people are under-treated. So we know that most of the hip fracture patients, most of the patients with vertebral fracture, and they are inadequately treated. So their hip is fixed, and they send hormone, calcium, and vitamin D. It's only a matter of time before they fall again, and then they fracture the other hip. And the people with a vertebral fracture, again inadequately treated, it's again a matter of time before they go home and fall again, and then get a hip fracture. So if somebody was mindful about the possibility of high fracture risk in these people should have been really treated. And also there's over-treatment of those who do not have a high risk of fracture. That is very common in countries like Sri Lanka and also in India. Let's say 55-year-old woman with a 10 years backache, which can never be due to osteoporosis. And then no clinical risk factors, is treated just because patient has got low bone mineral density. And that's a common occurrence. And then that actually should not happen, because that I'll come to the discussion later on why this patient should not be treated. Now I'm again actually going to give you a little discussion, a little involved in the little discussion how all this came about, like, how the T-score minus 2.5 led to treatment. Now, when these what I call diagnostic thresholds were introduced in 1994, and the clinicians were really, happy that, they got something to, fall back, like, some kind of, measurement that they can categorize their patients. And then what happened is that they considered this what are called diagnostic threshold, what are called therapeutic thresholds. And they thought that the patient with osteoporosis would develop fractures, and then patient with normal bone mineral density would not develop fractures, and they had no idea about what the patient with osteopenia would do. That was a bit of an unknown quantity. So the what is called the extrapolation of that diagnostic categorization by clinicians into therapeutic decision was that they thought the patient with osteoporosis should be treated because they all will develop fractures, and the people with the normal bone density should not be treated because they will not develop fractures. And again, osteopenia was an unknown quantity. And also this approach completely disregarded what I call other clinical risk factors. The main challenge for that kind of thinking came in 2004, and when this large body of epidemiological data were analyzed, you can see that this is what's called the T-score. You can see the T-score deterioration of bone mineral density, T-score getting worse and worse in this x-axis. And you can see what is called the risk of fracture. These red bars columns indicate what is called risk of fracture. Actually, not occurrence of fracture, the risk of fracture. You can see there's exponential rise of the risk of fracture with the bone mineral density decreasing. But if you look at these green bars, which are what's called the occurrence of fractures, and you can see most of the fractures have occurred among the people who have got osteopenia. It is not that, certainly patient with osteoporosis also that, fractures occurred among the people who have got osteoporosis, but then large number of fractures occurred among the people who have got osteopenia. And also that, people with a normal bone mineral density also develop fractures. So it's not unusual phenomenon for clinicians to understand. And we know people with normal lipids develop myocardial infarction. And so that's, that kind of association, certainly clinicians should be able to digest. So when this happened, and then people thought that it is the more than the diagnostic thresholds, what we need is what are called intervention thresholds, and see which patient need treatment, and then is not decided by what are called diagnostic thresholds of T-scores. So then came that the high risk of patients, risk of fracture should be recognized than the diagnosis of osteoporosis. So how do we do that? We do that if patient comes with a fragility fracture, if the patient, let's say, has had a hip fracture, patient has had a vertebral fracture or colles fracture, or one of those what's called typical osteoporotic fracture, and that patient should be treated. That patient should be treated regardless of the other things. For example, patient with a fragility fracture has a microarchitectural deteriorations and a structural failure. That is why patient got a fracture. If the patient did not have microarchitectural deterioration and the structural failure, patient wouldn't have got a fracture with a simple fall. So it's intuitive to understand that there's underlying microarchitectural deterioration. And also we know backed by the epidemiological data that people with the first fracture has got a high risk of getting what's called subsequent fracture. And then International Osteoporosis Foundation put it as what's called fracture begets fracture. So fracture leads to another fracture. So this is on epidemiological data. So this person who came with a fragility fracture should be considered for specific treatment completely regardless of the BMD. So if you don't have to do BMD, and that patient should be considered for specific treatment. And then only thing is that, secondary cause of osteoporosis need to be excluded. And also you have to ensure that there is a real fracture. And because sometimes something called epiphysitis in the X-ray can mimic a fracture. So we have to make sure it's a fracture and real fracture, and that the injury was a minor injury. And then if you establish that, and then that patient should be considered for specific treatment, and then you don't have to sort of look for a DEXA scan to do BMD. Here the BMD DEXA measurements is desirable but not essential in this situation. And then most of the patients can be treated. So I say patient with the fragility fracture requires treatment regardless of BMD outcome. I keep on saying this because, this is a group of patients who can be treated at anywhere in this country. And the usefulness of the baseline DEXA, and there are very few reasons why you should, if possible, get a baseline DEXA. One is that you can monitor the treatment on these patients, and then you can recognize what's called treatment failure, which is pretty rare. And most of my patients who had a problem with the treatment were the patients who are not compliant with the treatment, either vitamin D or the main treatment, and treatment failures are actually fairly rare. And also studies have shown that it is, if you had a baseline DEXA and then you get the patients and the relatives involved with the decision making, what's called patient-centered care, and then you can convince patients better, and then they will have better medication adherence. Studies have shown that. So the people who had a discussion with the doctors based on the DEXA scan and had a better medication adherence and a better understanding of the disease, rather than people who did not have that. So that's for those reasons, and it's desirable to get a DEXA scan on those patients, but really speaking, you can treat. So let's say if the patient comes without a fracture, without a history of fracture, and then you have to base your decision on the treatment decision, should be based on what's called fracture probability. And this can be determined by country-specific risk score. This is very much like a lipids and the heart disease. Now, if the patient comes with acute coronary syndrome, you are not worried about what's called lipid profile. You are going to have to give a high dose of atorvastatin, because high dose statin is indicated when the patient comes with acute coronary syndrome, regardless of the lipid profile. But if the patient doesn't have established ischemic heart disease, and then before starting on, let's say, statin, somebody will be calculating what is called the risk of, let's say, a vascular event within in the next 10 years, and maybe Framingham score, maybe a CVD, the risk calculator. One of those calculators, see what is this patient risk of getting a heart attack, vascular event during the next 10 years, and then before you write a prescription for statin. Similarly here, if the patient doesn't come with a fracture, and then you need to estimate what is called the probability of a fracture during the next 10 years. And then like Framingham risk score, you had to have a risk score here, and what is commonly used, what is called FRAX. The principles of fracture risk estimation in the FRAX is actually say that BMD is not the sole determinants of fracture. So which was earlier thinking, and they say BMD is the sole determinant, is gone out of window. And we say there are other determinants. Some of them are much stronger than that. For example, say muscle mass is much stronger than BMD in determining a hip fracture. And also these, what are called the other clinical risk factors, has come from the epidemiological data on a bit of a constant way. So this is one of those things saying that the fracture probability, there's a hip fracture, occurrence of hip fracture in different countries. You can see this, what's called Scandinavian countries and also European countries and the European nations. There's a high risk of, there's high occurrence of fracture when you compare some of the Asian countries. And people can still explain why this gradient or why this phenomena, why Asians have, less likelihood of getting hip fracture when you compare, let's say, a Norwegian or a Sweden person, and that is really is still people who do not understand that. And also that that you can see that given this thing BMD, the risk of fracture increases every time you add another clinical risk factor. Let's say there's family history of fracture, a glucocorticoid. So when you add a clinical risk factor, the risk of fracture goes up at any given BMD value, a T-score. So when you put all that into a, let's say, algorithm, now people talk about the algorithm these days, the AI has come in a big manner, algorithm, and you put that, you ask this question like, do you have rheumatoid arthritis or no? Do you take glucocorticoids or no? And have you had a prior fracture? Like that, you keep on answering these questions, and you can say that, depending on the answers that you give, and then you can determine what is the risk of fracture. You can see that, how the spectrum of fracture risk changes. So this is a FRAX, what is called calculation tool. And it's worthwhile making a visit. And then we got the Sri Lankan FRAX model. And in 2012, I think plus 2012, and who you hear is what's called Professor John Keynes, who was the leading scientist who got involved with development fracture, FRAX. And then you can see that when the Sri Lankan FRAX came, and even India did not have FRAX actually. They have got it now, but then even India did not have their own FRAX model. And when we got it, our FRAX model, so we developed, we got it that in 2012, I think, we launched it. Okay, so these are what are called the question that you have to answer. You select what's called country, and then you put the age and gender and weight and the height and the weight, and then you answer this question, the previous fracture, parental history of fracture, and all these in a bit of dichotomous manner, yes or no. And it will work. The beauty of the FRAX is that it will work with BMD, without BMD. And we have at least 3 publications saying that, that the Sri Lankan FRAX model has almost same output with BMD included, without BMD included. So that it works fine without BMD. So if you are working in a place where there's no access to DEXA, and you can assess the patient risk of fracture based on the FRAX, and then without BMD, because it won't make a much difference really. So you click the button here, and then you get into this kind of output, like what is the risk of a major osteoporotic fracture within the next 10 years, and what is the risk of hip fracture within the next, let's say, 10 years. So this is the as a percentage. So a better approach or newer approach here, based on what are called the intervention, what's called intervention or therapeutic threshold, is that when you get a patient, you look at what are called clinical risk factors, or plus or minus bone mineral density, and then you apply what's called Sri Lankan FRAX model here, and then you get what is called the fracture probabilities. And the fracture probabilities would vary from 0 to 100, and then you have to take cutoff value and say above which you would treat and below which you would not treat, what are called the cutoff value, intervention threshold cutoff value. And we have done actually 2 publications, and then we have said that major osteoporotic fracture more than 9%, and the hip fracture more than 3%. And then there is a fairly a decent cutoff value for you to decide on treatment. So at present, Sri Lanka uses what's called 9% for major osteoporotic fracture and 3% for what's called hip fracture in order to decide treatment. So anybody who has got a fracture risk more than 9% major osteoporotic, 3% hip fracture, and should be treated. So here we go by what is called a fracture probability and by bone mineral density or T-score. Now, this is what's a certain confusion among some people, and this is what's called the recommendation of the National Osteoporosis Foundation in the USA. It changed name recently, National Osteoporosis Foundation. And the National Osteoporosis Foundation recommends intervention for those with what is called the bone mineral density and osteoporotic range, and osteoporosis range. Okay. And if the patient has osteopenia, then they apply FRAX. And then if it is more than 20% major osteoporotic fracture, more than 3% in hip fracture, they will treat. So this is a kind of, the recommendation they made for USA and not for other countries. So this was developed in 2008, and recently they had actually looked at that again, and based on what is called economic principles. And then alendronate was the main treatment available at that time, and they took the cost of alendronate in developing these economic principles. Now that's not applicable because there are many other treatment options have come. And since it's on economic principles, you cannot apply that outside the USA. It is valid only for the USA. But unfortunately, many countries, including some Asian countries, they still use this what are called the NOF guidelines. And then you can see that if a certain DEXA scan, they shut down the FRAX if the patient T-score is less than 2.5, and they don't allow that FRAX calculation to come. This is USA, in a country where the DEXA scans are available even with the general practitioners and very widely available. Only country in Asia that has something similar to USA situation in Japan and Singapore. All the other countries in Asia has got very limited access to DEXA. So then other thing is that in the USA, the indication for DEXA are very tightly regulated. So a 55-year-old woman with a 10 years backache will not get a DEXA scan, and then, would get treated in the USA. For USA, somebody to have a DEXA scan, and then that patient has to have fulfilled those criteria. So it's not a huge problem in a country where the indication for DEXA are tightly regulated. And not like in Sri Lanka, like, 55-year-old woman, working in one of these companies and come for a medical checkup and then get a DEXA scan done. So that does not happen in other countries, in particular in USA. So this is one of the major problems that we have. It's not a major problem, but again, some people are still thinking that, NOF guidelines should be followed. And these are the Asian countries which shift from NOF guidelines, their local intervention thresholds, and as Singapore changed, and I got involved with the calculation of their intervention thresholds, and recently we did for Malaysia and also Philippines. Okay, let's go. What are the treatment options? Now, the treatment options available are the aim of the treatment is what's called the prevention of fracture, either the first fracture or subsequent fracture. So patient who did not have fracture, you prevent the first fracture. And the people who did not, the patient who develop a fracture, then you're trying to develop subsequent fracture. And also all types of fracture. And also you need to improve what's called quality of life. And those are what I call aims of treatment. I just run through what I call non-pharmacologic interventions. Nutrition, adequate protein, calcium throughout life is important, and particularly adults should have a higher requirement of calcium as well as protein. So you need to make sure that the older people get a higher protein requirement, unless they have renal failure or they have a proper calcium intake. The exercise is important because in the young age to maximize their peak bone mass, so they achieve higher peak bone mass if they do weight-bearing exercises, and particularly, let's say, skipping ropes and all that, things like that, which are very, very useful. And then the middle age, you need to maintain BMD because exercises would help you to maintain bone mineral density. And in the old age, without a fracture, with a fracture, and without a fracture, and then prevent bone mineral density loss and the falls. So things like a walking would be okay, but if the patient has got a fracture, and also the exercises should be done under the guidance of physiotherapists. And the most effective methods, as studies have shown, that when the exercises combined with the nutrition, with both combined, and then you get a better effects. Prevention of falls is very important, and it's a different lecture actually. Calcium and the bone inseparable. You can't talk about bone without a calcium, but the calcium deficiency lead to osteomalacia. There's a low bone means osteomalacia, not osteoporosis. And calcium supplements, the studies have shown that randomized clinical trials have shown that calcium supplements increase bone mineral density in the growing children and postmenopausal women, but then calcium had no effect on the fracture occurrence. So that you cannot really link calcium with the fracture when you come to what is called treatment. But then calcium and bone are inseparable concepts. But then giving calcium, you can really expect somebody to not to get a fracture. The pharmacological treatment prevents. There are drugs which prevent bone resorption. That is, they block the osteoclast, and then so they inhibit resorption, and these are what is called anti-resorptives. And there are ones which promote bone formation. They induce osteoblast, and their main actions are on the osteoblast, and they are called anabolics. So there are two main groups, but there are drugs which are called what's called dual action. They inhibit osteoclast while they are inducing the what's called osteoblast, dual action. There are other drugs what are called vitamin D and other vitamin D and derivatives. This is a list of drugs. I got a bisphosphonate here, 4-bisphosphonate, main bisphosphonate, alendronate, risedronate, solidronate, is bentonate. They all are very good actually. They prevent fractures and they increase bone mineral density. And the SERMs, raloxifene, is not very much used because it has no effect on the what's called the fracture. And the particular what's called Moore study has shown that it can prevent the first vertebral fracture and subsequent vertebral fracture. Even newer SERMs are unable to show an effect on what's called hip fracture. So it's a little bit of problem. Teriparatide was licensed in Sri Lanka, but it's not widely used because of the cost. I'll come to that later. And actually quite effective drug. It's quite good. The strontium granulate again is quite a disappearance from the treatment arena because it's not, again, there are problems with strontium granulate, never licensed in Sri Lanka. Vitamin D alone and calcitriol, and they have very kind of, the asterisks are saying, say that, they are not consistent like this what I call this positive effect that they are shown are not consistent, vary from study to study, like, because then you can't say they're uniformly effective. And the new drug which has sort of, unofficial use in Sri Lanka is not licensed yet, but then it is available, in particular in Colombo and all, what's called denosumab. And denosumab is again very effective drug. So drugs which we are mainly dealing with what are called bisphosphonate as a group, and teriparatide and the denosumab, and they are the very likely agent that you will come across. Bisphosphonate is increased bone mineral density about 2 to 5%, and it reduce the incidence of vertebral, hip, and then all non-vertebral fractures by 30 to 50%. So they're quite effective, and they're fairly well tolerated. Just run through the adverse effects. I don't want to spend a lot of time on that. There's hypocalcemia, which is transient, and acute phase reaction is the one which is you have to be very careful. And people, otherwise, they come back after 2 weeks and say, "Doctor, I can't take this. I got a fever, cramps, and all that." So you have to make sure that adequately warn them with the first 2 or 3 doses that you can get that, and particularly with the solidronic acid injection. So I generally give paracetamol before they take this injection, and then continue for about 2-3 days until the acute phase reaction wears off. There are gastrointestinal ones, of course, that we very well known. So you know the precaution that you take. So take on the empty stomach with a large amount of water, and then you try to flush it down to the beyond the stomach and all that that you know. And these are the 2 things that you have to be careful. What's called osteonecrosis of the jaw, and also particularly seen with IV bisphosphonate and atypical fracture. I've seen 3 atypical fractures as a result of that can be linked with bisphosphonate, and people who have been on bisphosphonate for a long period for unknown reasons. The period of treatment, oral for 5 years and IV for 3 years. I will come to that again. And then what you do is you reevaluate and decide. And then you don't Don't just drop it the treatment. Actually, you need to reevaluate and decide at that point, and then you see whether the patient has fulfilled criteria to stop treatment. So what are the criteria which came very recently? One is that there should be a significant improvement of the bone mineral density from the baseline scan. So is one of the reasons for you to have baseline scan. So you can see whether significant improvement will be a bone mineral density from the baseline scan. And also there shouldn't have been an incident fracture, no fracture while on treatment. So let's say 5 years treatment or 3 years treatment, patient has not had a fracture during the treatment period. And also no new clinical risk factor added while on treatment. For example, let's say patient had rheumatoid arthritis, wasn't on corticosteroids when the decision was taken to start treatment, and then let's say 2 years later, corticosteroids was started and then continued. So there's a new clinical risk factor added like. So there shouldn't be a new clinical risk factor added while on treatment. And also we insist that the total hip T-score should reach should be greater than minus 2.0. Is a 2.0 actually, 2.0. So it has to be in the range of about 2.0, that is 1.8, 1.5, minus 1.5, like that, because otherwise then you say there's no adequate bone mineral density gain during the treatment. Teriparatide is an anabolic agent and it stimulates osteoblast and many other actions. And it's a monthly subcutaneous injection given for 18 months. And you can stretch it for 2 years, but then usually it's given for 18 months. The cost is a drawback because it's prohibitively expensive. And before COVID came, it cost something like maybe 50,000 for an injection, but it must be pretty expensive now. There are safety concerns. And it is limited to those who are severely affected, even in other, let's say in Australia and other countries, it is given only for those severely affected. And 18 months to 2 years is the maximum period of treatment. And because there was a concern about what is called with the teriparatide, there was a concern about what is called osteosarcoma, and there's a black box warning on the drug. But then recently there's a little move, see whether the teriparatide, the black box warning can be removed, because now the people believe that actually it doesn't cause osteosarcoma. Denosumab is a monoclonal antibody to ranklin. And it is given 60 milligrams subcutaneous injection every 6 months, and it's quite effective, as I said. And it reduces all type of fractures, like new vertebral fractures, hip fractures, and non-vertebral fractures. Let's say initiation of treatment. You initiate with bisphosphonate. World over, bisphosphonate is the first line treatment because it's the mostly used worldwide. Is a cost-effective. Studies have shown that wherever you do is a cost-effective treatment. It has a fairly good clinical efficacy, and the tolerability is fairly okay. And also safety profile, we know that even somebody, let's say, got pregnant while on bisphosphonate, we have no concern about that now, because we know that it's a safe thing. And even there's a teratogenicity now, we do understand, not like earlier, let's say 10-15 years ago. You can start denosumab or teriparatide, but that is usually given for high-risk patients where the next fracture is imminent, like what's called imminent fracture risk that now people calculate. Where the rapid BMD gain is desired, like, you think this patient would get another fracture within the next 6 months, and then where the rapid, you should get the BMD, quickly achieve BMD, and then as a result of that, you can start either denosumab or teriparatide, because there the BMD increase is very high compared to bisphosphonate. So those are the people who have multiple fractures at the baseline, patient have a Colles fracture, 3 vertebral fractures, and maybe. And the recent fragility fracture with recurrent falls or low BMD, high glucocorticoid dose, and also those are the people who are likely to get another fracture within a short period. And also very low BMD is not, some people consider that also when you decided denosumab or teriparatide. When to stop treatment, and that is one of the critical points of bisphosphonate. I said you assess patients after 5 years oral and 3 years IV. If criteria I said earlier are fulfilled, you stop and continue with vitamin D. Please make sure you continue with adequate vitamin D. Assess after 1 to 2 years, either with the DEXA or with the bone turnover markers that we don't do very much here. And then if you think that patient has BMD deteriorated or the bone the metabolism, again, bone turnover has increased, and then you can restart if indicated after that period of, let's say, 1 to 2 years. That's mandatory that you leave that gap. If criteria is not fulfilled, let's say a T-score -3, -2.8, and then patient, that all the criteria is not fulfilled, there are two options. One is that you can change the denosumab. That is what most of the countries do. But since we don't have denosumab that for the wide use, and then you can continue bisphosphonate after discussion with the family and family members, and then the patient and the family members, and you can assess annually. So that's what we generally do. And this data come from what is called the one of the extension study, and they said that the bisphosphonate can be continued beyond 5 years. Data small number of patients, but again, it shows that it can be continued. And yeah, this is what's called the particular study, effects of continuing or stopping alendronate after 5 years of treatment, what's called flex extension study. And it showed that at the bottom, they highlighted how women at high risk of clinical vertebral fracture may benefit by continuing beyond 5 years. And this particular study gave for 10 years. When to stop treatment, teriparatide, patients assess patients after 18 to 24 months of treatment, and you don't extend treatment beyond that. And if criteria are fulfilled, you can stop and continue vitamin D, and reassess again after 1-2 years with DEXA bone turnover markers, and start anti-resorptive, because second cycle of teriparatide is generally not recommended, and you can give anti-resorptive agent if indicated. And if criteria is not fulfilled, again, you have to change either bisphosphonate or denosumab. What's called sequential therapy. After teriparatide, you go with either bisphosphonate or denosumab. And it's called sequential therapy for people who have remained high risk at the end of 2 years. Denosumab, usually you must assess patients after 3 years. And because that's most of the studies run for 3 years only. And if criteria again fulfill, you can stop and continue vitamin D. And again, same thing, reassess out 1-2 years. And again, you can restart denosumab like PTH, like alendronate, you can restart if indicated. And if criteria is not fulfilled, you can continue denosumab, because denosumab can be given for many years. Now, we know that, it can be given for many years, or else you can change to anti-resorptive. So that also can be done. You can change to, let's say, alendronate, or you can give PTH or something like that, and teriparatide. So you can change the treatment, or if possible, if you want, you can continue denosumab, because denosumab can be continued for many years and without major side effects. Therapies not discussed here are the what I call SERMs, calcitonin, strontium ranelate, and HRT, simply because they are less effective than bisphosphonate and questionable anti-fracture efficacy they have, and also because of safety concerns. I'm not addressing them, and also they are not in wide use. Vitamin D3 is mandatory as a co-prescription for all patients, but don't. And some people, they have a habit of poisoning people with vitamin D, like give about 5,000 every day or something. It's quite useless, really. All you have to do is about 800,000 interaction units per day. There's a very nice meta-analysis, and it shows that 800,000 is fine. That works. Vitamin D derivatives like 1-alpha and calcitriol should not be expensive, and the risk of hypercalcemia. So if you give it for a patient, and then you must always monitor their calcium level, because the risk of hypercalcemia much higher than with vitamin D3. And there are general reserved people with renal or liver diseases, and also for elderly who have a problem of absorbing vitamin D3 because of the little mucosal problem in the mucosa. Newer therapies which are coming to the has come to the market in other countries, like what's called lasofoxifene and the besodofoxifene, and we call it laso and the besa. And also romosozumab has come to the market in other countries, and abaloparatide also is a PTH derivative, and they are quite potent drugs actually, but they are very expensive and not available in most of the European countries. They are available, but not in all the countries. So in summary, many high-risk patients are undertreated or untreated or undertreated, and it's not a kind of local phenomenon. It's a bit of a universal phenomenon, and also many low-risk patients are being treated unnecessarily or irrationally. Attention should be paid to the fracture risk than the diagnosis of osteoporosis. So that the clinician has to do that, and say, I'm interested about the risk of getting a fracture than whether you have osteoporosis or not. And paradigm shift is that the diagnostic threshold to intervention thresholds. Now, people are not really worried about what's called diagnostic threshold. They're very much about what I call intervention threshold, based on what I call the risk of fracture. Aim of the treatment, prevention of fractures, either first or subsequent, and improves quality of life. There are many options, but bisphosphonate still lead the market. and just because of the cost effectiveness and the efficacy. The serious adverse effects are not uncommon, and you come across them every now and then, and also cost constraints, and particularly with the newer therapies, need to be considered. But that is my last slide. So thank you very much for listening. If you are still there.
Thank you very much, sir, for that comprehensive and thought-provoking lecture. And I'm sure our audience has much benefited from that excellent talk. Is that all right with you, sir? Shall we discuss the questions that have been forwarded, sir?
Absolutely, no problem. Yeah.
The first question is how to confirm microarchitectural deterioration to diagnose osteoporosis.
Yeah. It is not used in clinical scenario, but we use it, but it's called, we have a trabecular bone score. The trabecular bone score is a newer technology, and which was introduced maybe about, let's say, 5 years ago, and it is used in the what are called DEXA images, and then also applying a principle which is used in the structural engineering, it's called variogram principle, and then they find out the what I call the microarchitecture, where there are gaps in that bone image. And trabecular bone score, and if the patient has got low trabecular bone score, that the FRAX outcome, fracture probability, can be adjusted for that. But then we do have what's called TBS software that we bought. It's about a couple of millions, and then we have got software, and then we had done one publication saying that it does not really add anything to the what's called FRAX. And not only us, there are plenty of publications to say that the TBS, what's called trabecular bone score, which measures the microarchitecture indirectly, does not add anything to the clinical decision making over and above the currently practiced FRAX calculation. So then it came with a bang about, let's say, about 5 years ago, when you go to conferences and all that, they were talking about trabecular bone score, but then it's quietly bit of, going out of this thing, and it is used mainly for the research. But we don't measure that microarchitecture in this thing. But if you really want to do that, what you need, the micro-CT. And then micro-CT scans can do that, can look at the real, what is called trabecular structure.
Thank you, sir. I have one question of my own.
Yes.
When we are interpreting especially this lumbar spine, there are instances where the L1, L2, the T-scores are minus 2.5, but sometimes L3 and 4 has normal values. So the total, the cumulative value comes to say for example -2. What do we do on those occasions, sir?
Very good question. This actually will come to a nitty-gritty on the interpretation of DEXA. Now, DEXA, when you look at the let's say lumbar spine DEXA scan, you run through your eyeball and see whether there's what is called the vertebra to vertebra discrepancy. Now, there shouldn't be more than a unit change of the T-score between two adjacent vertebrae. For example, let's say L1 can be minus 2.5 and L2 can be, let's say, minus 2.0, because it's not a 1 unit difference. Okay, other one can be minus 2.8. So generally, there should be concordance of the T-scores from L1 to L4. So when you say concordant, it should not exceed more than 1 unit. But let's say if the patient has got a minus 3.5 in one vertebral one, and then next one has got, let's say, minus 3.4, and the next one has got a minus 1.5, right? And then you say, hang on, there's a little problem with the L3 vertebra. So L3, so here what you generally feel is that the L3 vertebra bone mineral density has erroneously gone up because of some reason. So possibly there's an artifact or there's a fracture. When there's a fracture, the area becomes less, and then the bone mineral density goes up. And also that when there's a fracture, there's a callus formation, and the bone mineral density goes up. But commonly, what we find is that what are called osteophytes, when there's a cluster of osteophytes near the vertebra, and again the bone mineral density goes up. So here you have to scan eyeball the DEXA vertebra from L1 to L4 and see which vertebra are behaving same manner and which one is the odd character, and you remove that character and then look at the make a decision based on other vertebrae. For that to be done, you have to have minimum of 2 vertebrae adjacent. For example, there are 4 vertebrae, and if one vertebra you think is a problematic, you kick it out, right? And then you make a decision on the remaining 3 vertebrae. And if you say another vertebra is a problematic, and then you remove that, and then you make a decision on 2 vertebrae. But that's a minimum number. You can't go to 1 vertebra and then make a decision. And those 2 vertebra need to be adjacent. So you can't take L1 and L3, or you can't take L2 and L4. They have to be either L1, L2, or L3 and L4. Right. So in the scenario that you give, is very likely what has happened is one of those vertebrae is abnormal. So there's either, let's say, large calcium plaque of the aorta or something like that, sitting on that. That also happens because aorta is next to that, just above that. And there's a large plaque of calcium in that, or there's a vertebral fracture, or there's a cluster of, let's say, osteophytes in that vertebra, and then erroneously increase in the bone mineral density, and then, upset in the final calculation. So you decide on the vertebrae that you believe are behaving in a concordant manner. I don't know whether I give a...
Yes, sir. Yeah, of course.
Okay.
The third question, sir, when starting HRT, before that, should we do a DEXA scan? Yeah, that was the question, sir.
Problem is that, why you start HRT. Now, the HRT as a treatment of osteoporosis is very, very rarely used. It's used in other countries, not very much in Sri Lanka, because of the problem of that, now, this Women Health Initiative study, which sort of, came and then, completely changed our thinking about HRT and risk of breast cancers, as well as the risk of, let's say, thromboembolic phenomena. And because of that, HRT use has become less. I know VOG still use, and then you need to have a mammogram and then family history and all that elicited in order to give HRT. So they are given for the people with the let's say very severe vasomotor symptoms and in the soon after menopause. And then if there's a low bone mineral density, and then you can justify the use of HRT and saying that, well, you have got a vasomotor symptoms and also you got low bone mineral density, and then HRT would be the best treatment to give. So in that way, it helps you to sort of, strengthen your decision or support your decision to use HRT. And otherwise, HRT as a treatment for osteoporosis is not discussed very much really, and it is mentioned in all the textbooks they mention, and particularly given for the soon after menopause people with osteoporosis, it can be used, and because it particularly look after the postmenopausal symptoms as well. But then when you look at the kind of the trouble that you have to take, like measure the endometrial thickness, and then the yearly mammogram, and then all that and all that, people think there are better drugs that can be used without all that trouble.
Thank you, sir. I think we have discussed this. The question is, Scandinavian countries get more osteoporosis fractures due to less sun exposure?
Yep. Okay. Yeah, it is. It's that's what actually people think, and then people think that is something to do with vitamin D. But then the studies have shown actually it's nothing to do with the vitamin D really. And then people thought that they may be sleeping on what's called black ice, but then they found that most of the fractures occurs indoors and not outside.
Yeah.
So this debate about that, whether it's a vitamin D, is it sun exposure, is it because of the what is called the hip structure, like because those people are tall and they have got what's called long femoral neck, and the long femoral neck is known to be a risk factor for hip fractures, and also what's called a neck shaft angle. And so there are a lot of things in discussion, but then no one has been able to sort of show that. For example, let's say if you take a northern European, if you divide European what's called northern Europe and the southern part of Europe, and then you can see there's a disparity of the fracture risk, because the northern part has got a high risk of fracture compared to the southern part of Europe. And so it is something that is something people are still struggling to explain fully why we do have this kind of situation.
So we have nearly 16 questions. Is that all right with you?
Yeah, I'm fine. No problem with that.
So, what is the role of calcium supplementation in the treatment process?
My God. I because you know that we had a huge problem with the calcium marketing and with osteoporosis, and then
Yes.
some of the other managed to get them dissociated from the osteoporosis word and fractures, because that has nothing to do with that. That was a real struggle. Now that they should have enough calcium, so that's for sure. So I generally inquire about their food behavior and whether they take some our calcium intake in the form of dairy calcium intake. Generally, we are very poor in that. So I make sure that they take small fish which are eaten with bones, and that's quite good actually, because it has got plenty of vitamin D and also plenty of calcium. So I encourage people to take small fish and which are eaten complete with their bones and all. So that's fine, something you can do. Problem with the green leaves is that the green leaves calcium is not biologically very, but you know, bioavailability is questionable because of the phytate and the phosphate. So if you think somebody has got intolerance to milk, and then not willing to take vegetarian and doesn't want to take kind of this thing, and maybe you can give calcium supplement in order to provide 1200 milligrams of calcium. But most of my patients, I didn't have to do that. And also we can think of what's called, there are vitamin D preparation, which are there are certain preparations where vitamin D and calcium both are available in this thing, and then that you can give some of those tablets where the calcium and the vitamin D are combined.
The fourth question is, why not giving bisphosphonate in acute fracture state?
We do give. That's no problem, because now earlier there was a little problem. This happened about maybe 10 years ago. There's a little concern that, among the orthopedic surgeons, really, that, if you give bisphosphonate, the callus formation, the fracture repair would be impaired. So they went to the lab, and then, they took animals and they broke their, legs, and then, then all that, they did a lot of experiments, and then found that actually bisphosphonate do not interfere with what's called fracture healing. So when this patient comes, actually what most of the centers they do, like, even other countries, they give either solidronic acid, that, as a one shot, and then before they send. Otherwise, they are unable to generally follow that, what is called that the little things that they have to do in the morning, like, get up and then, all that, they're unable to follow now with the fracture. So if you give a shot of solidronic acid and then add vitamin D, generally it works. Or you give something like denosumab injection in other countries. So that generally we encourage orthopedic surgeons to give that, because that doesn't interfere with the fracture healing.
Dr. Dasun asked, when do we consider starting solidronic acid as a first line? I think.
Do we consider solidronic acid a first line?
First line, yes.
Yeah, I generally consider solidronic acid as first line, because the compliance with oral bisphosphonate become really questionable, and because it's a funny tablet that they have take, like, they're happy with tablets taken twice a day, once a day, that they have heard about their nose, and when they go to the village and say, look, yeah, I'm taking a tablet, once a week, and all, they say, what's this? And then, so then the patient stop that. So now if you give a solidronic acid, and then it's not very expensive in the form of, let's say, if you go for a 5 milligram solidronic acid, it become pretty expensive. But it's called only we have got a generic in this country. Sorry, the original in this country. But again, if you go for, let's say, 4 milligram, which I believe is sufficient for people, because people are small made anyway. So 4 milligram on the Indian preparation, it doesn't cost much really. So if the patient, I discuss with patients really what are the options, like, would you like to go on a weekly tablet, monthly tablet, or go on injection? And then if some people are happy, I offer solidronic acid. And if you want the evidence show that the solidronic acid gave a better fracture prevention than, let's say, oral bisphosphonate. I think simply because of the bioavailability and the compliance. So those two issues are kind of, did not come when you get solidronic acid, and as a result of that, they had a better fracture prevention. So that you can give, if the patient is happy, you can do that.
Dr. Chaturanga, what is the accepted BMD when the patient is put on bisphosphonate on repeat imaging in 5 years?
Say it again. I didn't get that.
What is the accepted BMD drop, sir, when the patient is put on bisphosphonate on repeat imaging in 5 years' time? So I think he's asking about stopping bisphosphonate on BMD.
That's right. That's a good question, really. Now, let's say generally these people they lose bone mineral density in the range of, let's say, 1%, 3%, like, you know, that's okay. But if somebody loses bone mineral density more than 3%, and then we call it a rapid loss of, it's what's called rapid loser. Now imagine if you get, let's say, a 50-year-old woman who has got a menopause, and then the people, they lose bone mineral density from, let's say, some people don't lose, and then going up to 5% like. And if you're losing 1% like, you know, after 10 years, you may have lost about 10% of your bone mass. But again, if you're losing at a 3% per year, then you have lost about, let's say, 1/3 of your bone mass after about 10 years. Let's say now you're talking about 60 years, and then people are still working, and then, you know, they are still running to catch their train, and then, you know, bus and all that, you know. But again, 30% of their bone mineral density is really compromised. So those are what are called rapid losers. So if somebody has got, let's say, a reduction of bone mineral density more than 3% between 2 scans, and then you say that's a significant drop, then I generally discuss with the patients and then see whether they would like, because some people, it's difficult to get them to, you know, agree on that, because they say, no, I don't have backache now, I don't have to take treatment, this and that. But generally I offer when it is more than 3%.
Right. Fourth question, sixth question. When do we decide on treatment of osteoporosis in young patients? I think this is beyond our topic. He's asking about the young patients who are on steroids for autoimmune diseases.
I thought somebody might ask that question. I got two slides prepared. So is it wrong? Is it okay if I show other two slides?
Of course, sir. Sure.
Yeah, because I really got involved with the bisphosphonate, the glucocorticoid-induced osteoporosis, because first time in the Royal College of Physicians, London wanted some guidelines. I was in UK at that time, you know, and then we developed first set of guidelines, and then again we developed again guidelines in 2014 European guidelines, and then I was involved with that as well. I know about this one. I can get my slides moving. All right, okay. Yes, now, this is prevention of glucocorticoid-induced bone loss. Now, earlier we had a huge debate, you know, what dose we should consider. And then the first guidelines, when you wrote for the Royal College of Physicians, we said 5 milligrams and above. But now they say any dose of glucocorticoids for more than 3 months, that, you know, you have to, that's the time that you should, you know, think of, you know, giving some protection. So any dose of glucocorticoids for more than 3 months, because this evidence came from what is called the UK GP database, and huge database. And then that's what they say, even 2.5 milligram increase the risk of hip fracture, and that is published somewhere. So you take general measures like keep the dose and the duration the minimum, use alternatives, consider local formula, and all that. We all know that in even pharmacology, you know, why we used to say that. The non-pharmacologic measures like control underlying diseases, that's very important. And because sometimes underlying disease itself has effect on the bone mineral density, so it should need to be controlled. Then the nutrition, physical activity, sun exposure, they all need to be sort of, you know, looked after. And vitamin D should be given for all people, because steroid upset the vitamin D metabolism. The vitamin D level goes down, so the vitamin D should be given when you're giving corticosteroids. And then you come pharmacologic treatment, how to decide. Let's say if the person is more than 40 years, and treat when the fracture is detected. Let's say a person more than 40 years, there's a fracture, you treat this patient. Don't think of anything else. You have to treat this fellow. When it's a fracture, it's a fragility fracture, low energy fracture. But if the patient more than 40 years without a fracture, then you can fall back on what is called frax, because although frax is actually the data used for the frax is from 50 years onward. And then the what is called the people who are architects of the frax, they tweak it a little bit so that if you enter the data 40-year person, it is treated as 50 years. So still you give what is called the frax output. So 40 years onwards, you can apply frax. right? So let's say on that what is called clinical risk factors, you can use that what is called the BMI, height and the weight will come, the age will come now, and then the rheumatoid arthritis story will come, secondary osteoporosis story will come, corticosteroid will come. So all that get in there, and then you can use fracture and then calculate fracture probabilities and then make a decision based on that. Okay. And then recently there was a little bit of, criticism on the Frax saying that Frax uses the corticosteroid, this thing as a yes or no. But then we know that the risk of fracture is a dose dependent. So because of that, now there's a little bit of adjustment that can be done for the dose. Let's say if you are taking more than 7.5 milligram and then you multiply by 1.2. So there's a little adjustment that you can do for the Frax outcome depending on the dose. So that based on that, you can decide to treat, because if the patient's the fracture probabilities increase beyond that intervention threshold, those people can be treated. But let's say when the patients are less than 40 years, no guidelines give a clear guidance on these things, and they are very, let's say, hazy about this area. So less than 40 years, what I generally recommend is that you consider treatment when there's a fracture. Of course, when there's a fracture, you have to treat. So there's no question about that. Even patient less than 40 years, fracture, you treat. But if patient hasn't got a fracture, then you must consider what I call underlying disease, nature of the underlying disease. For example, if the patient is getting corticosteroids for minimal change glomerulonephritis, in contrast to inflammatory bowel disease, you know that the patient with inflammatory bowel disease will have a more problems than patient with minimal change glomerulonephritis, because minimal change glomerulonephritis itself does not have effect on the bone, but inflammatory bowel disease would have effect on the bone. So then you consider whether it's inflammatory or not. And then you think of the dose of glucocorticoids and also consider the BMI of the fellow and the risk of falls and limited mobility. You take all these into the consideration and say, hang on, I think this patient needs to be treated. So this patient less than 40 years who has not got a fracture, and it is left to the clinician to decide based on these things. These are the things that you can fall back, right? So I think, is it okay?
Yes, sir. It is clear. It's pretty much clear.
Thank you.
Yeah. Thank you, sir. And the next question is, yes, we have, I think, answered how much calcium needs to be substituted.
Right.
How do we treat renal failure patients?
Yeah, this was, where did we discuss this? I think in the endocrine, I think last endocrine slender, we were discussing this. Renal bone disease is a huge subject because it's not only osteoporosis, you've got osteomalacia, osteoporosis, adenemic bone disease, secondary hyperparathyroidism. They all are like, operating in that situation. So really, unless you have done what's called your histomorphometry, you don't know what you are doing really. So generally, these people need a very good evaluation in the sense their PTH level, vitamin D level, calcium and the phosphate and everything to see which kind of disease that you are talking about, right? So if the patient has got a secondary hyperparathyroidism, then of course treatment would be different in contrast to patient who got osteomalacia. And then you exclude all that, like it's not osteomalacia, it's not secondary PTH, like, all that. And then, then you had to treat with what's called the anti-osteoporosis drug. The drug which can be used at the moment are only two. One is that the solidonic acid could be given only if the EGFR more than 30. If the EGFR more than less than 30, solidonic acid can't be given. So there also what we do is we give half a dose, 2 milligrams solidonic acid if the EGFR more than 30, right? But other drug that can be used, what is called denosumab. Denosumab is a water-soluble drug. And in contrast, let's say solidonic acid, which is not a water-soluble drug, and it gets deposited in the hydroxyapatite crystal very firmly. And the denosumab is water-soluble. It is in the plasma. So it has a less nephrotoxicity when you compare the other drugs. So denosumab would be a treatment that you would consider, but still you need to monitor the renal functions. So it's a huge subject itself with the books and books are written. So if you narrow it down to osteoporosis and say it's not secondary PTH and it's not osteomalacia, and then you might treat that patient with either half dose of solidonic acid with the EGFR allows, or else you might consider giving a denosumab.
And that's an interesting question. Can a GP start alendronate to a patient who fulfill the criteria?
Say that again.
Can a GP start alendronic acid to a patient who fulfill the criteria?
I think yes. Because
Yes.
in other countries, it's practiced in other countries as
Yes,
long as
yeah.
they know what they are doing.
Yeah.
And yeah, that I mean, I have seen that given alendronate given for 3 months and stopped, like some
Yeah.
prescriptions, and
Mhm.
it is given along without vitamin D. And I have seen all sort of things like because I have seen somebody was treating a patient with osteoporosis just away one vertebra was less than -2.5. All the others were more than that, and then that patient 50-year-old innocent teacher and was being treated. So I
Yeah.
seen all that but as long as GPs know what they are doing, and then I think it certainly can be done. In other countries, certainly GPs treat. For example, if you go to Australia, now Australia, the first line drug has denosumab become the first line drug. I don't
Yeah.
know how much pharmaceutical this thing is there, but GPs can treat, I think.
And yeah, and to follow up these patients, isn't it?
Follow up.
Yeah.
Yeah, as long as they know what they're doing, like I mean,
Yeah.
for example, let's say if they know how to manage a patient with a lipid abnormality or diabetes,
Mm.
and they know how to follow up that patient with diabetes, like these are the tests that you should do annually, and then eye examination, ophthalmoscopy every year. If they know that how to do that, and if
Okay.
they do that, then of course there's no problem. So likewise here, if they know what they're doing, and if they know they understand the subject, and certainly they can do that. But my question is that because I don't think there's a dedicated continuous medical education program targeting GPs and all, and then they don't get their knowledge updated and all, and I mean just so that might not work really.
Mhm. And do we have to do, that's another question, do we have to do dental assessment before starting this performance?
At least I look at their mouth, and there are two
Mouth,
things
yeah.
I do. One thing is that I check their calcium level. I do not check their vitamin D level for some reason, because that's vitamin D. If you check that, there's definitely low, and
Low.
you're going to give vitamin D anyway. About 50% of our population vitamin D are either deficient or insufficient. So that is another story. I check their calcium level, and also I check their pulse, and to see whether they have got atrial fibrillation, because one of the adverse effects of bisphosphonate is atrial fibrillation. Other thing is I look at their mouth and then see whether they need any dental like extraction, loose teeth and the broken teeth and all. And if they do, then of course I send to dental surgeon. If not, I generally I handle them in my practice.
And there's another question. In osteomalacia, what happens to the DEXA BMD?
Good question. The DEXA cannot differentiate between osteomalacia and osteoporosis. And they all have low BMD. For example, let's say if the patient got osteogenesis imperfecta, and then again what you get is a low bone mineral density. So low bone mineral density cannot differentiate whether it's osteoporosis or osteomalacia. So when we send our recommendation to the referring consultant, we say that these are this is the patient got osteoporosis, what the fracture risk, and then consider treatment after underlying causes are excluded, like because we want them to run this battery of investigation like ESR, full blood count, calcium, and this and that. And then if the patient has the symptoms which are suggestive of osteomalacia, like proximal myopathy and aches and pains and this and that, and then it's worthwhile, thinking of that possibility, and then excluding that, doing maybe alphos and things like that. But DEXA cannot differentiate between the two.
Between those two. Thank you very much, sir. And I think that is all the questions that we have run through all those things, and we have had nearly 125 participants. Up to now, we we have gone up for 1.5 hours of the session. So thank you very much, and I think it was very enlightening and comprehensive, sir. Thank you very much again.
No problem at all. It's a pleasure. Okay.
Thank you, sir. Thank you very
Okay,
much.
okay, bye.
Bye.